Yes, so I will talk about the idea of using sensor technology to support lactation. Here are my disclosures. Perhaps most importantly, I am not an engineer, but I will certainly do my best to relate the concepts. And I do want to start with um, emphasizing that the work over these years was a collaboration across disciplines. I think very important one, including bringing together clinical minds and engineering minds. And we think so differently and in complementary ways about solving problems. And so I think it's a big strength. There were many others involved in this work, but key people that deserve attention include Doctors Jennifer Wicks and Craig Garfield. They're here in our Division of Hospital-Based Medicine, but their clinical work is entirely in our neonatal intensive care units. Dr. Jihei Kim was at Northwestern in a postdoc position during the vast majority of this work, and she was really instrumental in, she was in the School of Engineering and instrumental in the preclinical benchtop iterations, rapidly moving things forward, coming back into the NICU for clinical testing. And we were so lucky that she was a part of the team, and she's now has a faculty position in Korea. And very importantly, Dr. John Rogers is in the McCormick School of Engineering at Northwestern. He is an international leader in engineering of technology that is specific to healthcare. And then even within that, he has this niche where he works with devices that are skin sensors. So his engineering expertise was really critical. And so the clinical experiences that myself, Dr. Garfield, Dr. Wicks, that we've had over and over again really informed this seedling idea. And there were a couple of key reasons that this stuck in our mind. First, it was a repeated experience. So there were numerous infants, numerous families that were being impacted. It was an issue that was coming up during our clinical rounds in the NICU. And the short of it is these experiences centered around the issue of lacking objective information. And we're in this ICU, you think we should have all of these objective data or pieces of information at hand, and repeatedly we were without. And so just to do a little bit of a case example, we would be rounding on a preterm infant. It didn't matter whether they were born extremely preterm, late preterm, so born in that 34 to 36 weeks gestational range. There would be a prescribed feeding amount that the infant would eat every 3 hours. And because of the state of the infant's maturity and progress, some of the feedings were occurred by mouth, but some of the feedings were provided by nasogastric tube. And the mother or birthing parent had started to feed at the breast. And we would be standing there, the whole team, the parents, the nurse, and the NICU nurse would ask how to manage the volumes for these feedings, because nobody had information about the actual amount that the infant would ingest or consume during the direct breastfeeding portion. And so the decisions we were making were subjective. We'd say, oh, well, how did the feeding go? How long did it last? Like that told us anything about feeding volumes. And so these decisions were impacting, feeding progression. There were implications on discharge preparation and setting expectations for families. So we had a common problem. We felt like it needed to be addressed and that it could be addressed. And so the opportunities for sensor technology to improve lactation and breastfeeding outcomes included reducing this uncertainty in milk volumes that infants get during breastfeeding. And it's an opportunity to provide a wireless sensor that is easy to use. So if we, develop something that is really accurate, but it's cumbersome and complex, that is not going to facilitate utilization. So this low burden is a phrase we use repeatedly. There's an opportunity to facilitate and manage specialized medical circumstances that include prematurity, but really extend beyond that to any feeding pathology in infancy, no matter what the underlying diagnosis. And we think a lot about our complex patients that we care for in our children's hospital, our quaternary care NICU. And of course, there's opportunity to support achievement of global public health breastfeeding goals. The concept, the sensor, it stemmed from experiences around prematurity, but it's perfectly relevant for healthy full-term breastfeeding dyads. And I've also wondered and believe that there are research applications for low burden assessments of volume intake in various research settings. So now I'll take you on the path to our current sensor, which is very, very different than where we started. This first picture shows you two sensors. The AAA battery is there just for size context, but this was our original idea. These sensors were placed on the infant. We started off thinking that we should or could sense the flow of milk. And therefore, we had sensors in a couple of places, the jaw on the infant, the suprasternal notch just above the breastbone, and actually even opposed on the back. And this wasn't to get swallowing or, swallows by the infant. We know that's not accurate. It was to sense the flow of milk. We had some kind volunteering by physician parents. We were able to do some testing, but the bottom line is it was not going to work, and we needed to move along in our ideas, our methods, and that was a big shift in where the sensor would be placed, and that brought us to breast sensor technology. So the next broad method that we worked on for quite a bit of time was photo detection, using an LED, such as at the top of this model, to send a light signal to a photo detector across the breast, and you see that at the bottom. And so we did initial testing and some clinical testing. The initial testing was on a non-pregnant, non-lactating individual, just to start working with that light sending and receipt by the sensor. I'll also clarify now that the work that I'm going to talk about in the testing moving forward, that occurred with pumping. At the start, we needed to know what the milk volumes expressed from the breast were in these initial stages of testing. So this is largely about testing during pumping. And I'm showing you now examples of the data that we were able to get using the photo detector system. So we see the LED and the photo detector in these two different scenarios. And in this first scenario, I'll also mention one of our earlier requirements in the first stages of testing. We would often have sensors on both breasts, the pumping breast and what we call the control breast. So we would record while the one breast was pumped, but the other breast had no milk expressed. So that's why we're seeing the two different curves here. But across this 4 minutes of testing, as you can see on the x-axis, and in the pumping breast, in those red lines, we had pretty good correlation between the signal and the milk output volume that we measured by tabulating with the bottles. However, when we increased the distance between the LED and the photo detector, the signal strength was far less. Simply, the signal did not correlate with milk output volume. So there was some progress, there were some limitations, but we did proceed with testing. Now, I mentioned the long-term goal of getting to a wireless sensor, but I'm also showing you, again, this whole path. And we needed to start initially with a wired system, which allowed sort of these rapid iterations early on. And when I show this, it looks a little Frankenstein to me, but this box and the wires, this was part of the original system, just to give you some context of the path. So moving to wireless then required a battery in the system. So just initial layouts, we have the the photo detector, the LEDs, all connected here to a small external battery. And we always had the goal of, soft, comfortable, stretchable material. And that led us to, again, an early mock-up of the system, which we did utilize in some of our testing. This is an actual graph from our planning documents. We then had to map out, with the sensor in place, the mom sitting in the chair with the pump, et cetera, how do we proceed through that pumping session? And in the very first testing, we felt it was critical to get the most accurate milk volume. So we would have a couple of minutes of pumping, and then this, what we called rest period, we would actually remove the bottle, put it on a scale to get that accurate volume, replace an empty bottle. We also didn't want it to be a rushed situation. And we would repeat this cycle for 15 minutes. And then the mom would continue pumping without interruption for the remainder of the typical time frame. Now, with all of this, and this is quite a summary, ultimately ambient light was prohibitive to this system. And we knew that ambient light was interfering with the signal on the photodetector side. And we did try some things, ideas that the engineers had to cover that portion, different materials, but it moved us away from that idea of easy to use, not cumbersome, and comfortable. Some of the materials were actually going to be uncomfortable on the skin. And so in short, we had to move away from that system. And so with further brainstorming by the engineers, we've landed on bioimpedance, and that is the system that we've tested, we recently published, and we are continuing to advance from. So just as a short primer, and I'm going to mention this again with a bit more context, bioimpedance involves sending a very weak current through tissues, through fluids. They all have different conductivity. And then we measure the resistance to the flow of that weak current with the receipt of the signal at another detector. So it's sensors communicating with one another. With just about every step, every different system, we've always had preclinical testing, including bench testing. And this is work, again, that Dr. Kim led. And it was really critical that it happened before we were in the NICU working with research participants. So the engineers would generate these models that created some compartments, not anatomically correct, but enough to give them some preliminary information. In this system, we see this artificial skin, some agar with sodium chloride. There's a core where milk could be infused and then removed. So there could be some control over the volumes that existed and then were pulled out. And then Dr. Kim could work with, we had a 4-electrode system initially. We've got our current and voltage electrodes, and she could work with different distances between the sensors and do a lot of preliminary work. Now, the engineers also did a lot of background work in understanding the electrical conductivity of all of the different tissues and fluids in the breast. And these are just examples to show the concept that we have electrical conductivity and that there is lower conductivity and then higher conductivity depending on the tissue or fluid. And so to come back to bioimpedance, we're sensing the resistance to a weak current. And if milk has the highest conductivity, as that milk is removed, either in the benchtop system or during pumping or during breastfeeding, then there will be more resistance. And so we're really talking about a change in the impedance, or this delta Z, fundamentally. And so we were able to test this wireless system on 12 individuals. Those individuals did serial testing sessions. Up to 4 was the most in one individual. These were mothers whose infants were in the neonatal intensive care unit at Prentice Women's Hospital. And just looking at some basic demographics, the gestational age at delivery, the median was 32 weeks, but the range, including moms who had delivered full term, about 42% were primiparous, and about 3 of the moms had delivered twins. So what did we find? The figure on the left shows the system where we have our 4 electrodes. They were essentially in an arc outside of the phalange. So the electrodes never touched any of the pumping system. And here, BLE, this is Bluetooth communication between the sensor and a smartphone to transmit the raw bioimpedance data. The engineers did need to clean and transform that data. And then we ended up with a curve such as this on the right, where we have our MILC output volume, we have the individual participants in each line, and then we have this cleaned and transformed bioimpedance data. And how do we translate that? Our key results were that the mean MILC output volume recorded versus inferred from the bioimpedance system differed by 0.1 milliliters with a standard deviation of just under 5. And we had no adverse skin reactions. We did monitor for that. So where do we go from here? Just 2 last slides to wrap up. So we need to test this during direct breastfeeding. We see our system here and the infant at the breast. So while there was great progress during pumping, that was testing during pumping. We need to account for infant moving, different holding positions, the mom perhaps moving, things like that. We also need to assess, how do parents feel about this technology? How do clinicians feel about this technology? And how do we, as the investigators, remain confident in the technology? And this is the work that we will do in grants we just submitted and in our future grants. And very finally, just to show some of the technological advances that have already occurred since our publication, I showed you the 4-electrode system, a huge advance, pretty darn accurate, but still there's some limitations in the positioning. And so far, if we can increase to 5 electrodes, this allows some flexibility for the user in the positioning. And so I talked about preclinical benchtop testing. Well, the engineers can also use computerized phantom breast scenarios to mock up different systems. Here's an example where we have our 5-electrode system. We see the flow of current. And with 5 electrodes, there's more back and forth communication, and that allows us the flexibility. We also, in this cross-sectional view here, see how the electric field changes with more or less MILC in the core. Again, this is all computerized modeling. So our future work is to be testing during breastfeeding. And so with that, I am happy to answer any questions. There's a whole lot more to share, but again, thank you so much for the opportunity.
Awesome. Thank you so much, Daniel, for sharing this. I love that it wasn't just here's what we've done, it was the story of how you got there, because in all forms of science, that's so important and we rarely talk about it. So I like to see the so-called failures, which are all about learning.
Totally,
Um,
yeah, yeah.
nice.